Thank you very much, and it's very nice to be here. I'm Janine Wieland. I'm a psychiatrist in the Netherlands, working both in mental health care and in ID care, and my special interest is borderline intellectual functioning, so I'm very happy to talk to you about borderline intellectual functioning in mental health care in the Netherlands. And I want to explain how come we actually know some stuff about borderline intellectual functioning in mental health care. I'm going to tell you a little bit of the things we know. I'm going to tell you about borderline intellectual functioning in both ID care and mental health care. I'm not going to make a comparison. I should have taken that out. We have no time. But I do want to talk to you about the core elements of good care as we formulated them in the Netherlands. And the first reason why we know so much about borderline intellectual functioning is actually because in the Netherlands we often use a broad definition of mild intellectual disability. And as probably you all know, you have a mild intellectual disability, or you have an intellectual disability when you have an IQ of about 70 or less, and problems in adaptive functioning. And in the Netherlands, and this is a Dutch curve of intelligence, when you have borderline intellectual functioning, which is an IQ between 70 and 85, and if you have problems in adaptive functioning, we also tend to call that mild intellectual disability. So the funny thing about the term mild intellectual disability in the Netherlands, that if you use the broad definition, very likely actually the mild intellectual disabled group, most of them actually have borderline intellectual functioning. And we know that also because when you look at the amount of people who cognitively function as having borderline intellectual functioning, who have also problems in adaptive functioning, this is a very large group. And again, I didn't know how to translate this slide, but we have about 2.2 million people with borderline intellectual functioning in the Netherlands, and about 1.4 million of them are suspected to also have problems in adaptive functioning, which is a little over 60%. So actually, in the broad definition of mild intellectual disability, we're most likely actually talking about borderline intellectual functioning. So the other reason we know a little about borderline intellectual functioning in the Netherlands is because we have a screening instrument. The English translation is a screener for intelligence and mild intellectual disability. But again, it's the broad definition of mild ID. But it helps us to identify those people who are very likely to have either borderline intellectual functioning or mild intellectual disability. It's a quick test. It has about 14 questions. You can, like almost everybody can use it. You don't need any special training. It takes up to maybe 10, maximum 15 minutes, and it has a pretty good sensitivity and specificity in recognizing both borderline intellectual functioning and mild intellectual disability. So the third reason why we actually know some stuff about borderline intellectual functioning in the Netherlands is that we keep the door ajar to ID care for these people. So if you have borderline intellectual functioning and significant problems in adaptive functioning, you are allowed care from the CARE Act for people with an intellectual disability. And the problem is that we don't have very strict rules about who can and cannot get that kind of support. And often when there's a comorbid mental health issue or a psychiatric disorder, it's very difficult to get this kind of care, because people will say, well, you have to first treat the mental disorder and then see if there are still so many problems in adaptive functioning before you can enter this kind of support. So the fourth reason why we know so much about borderline intellectual functioning in the Netherlands is because we are actually including them in standard quality of care. And we have developed a lot of quality of care standards in the Netherlands in the past year on the subject of mental health, and we actually have one that has the subject of mental health problems in people with either borderline intellectual functioning or mild intellectual disability, that talks about explicitly about good care for this group of people, and it's very patient oriented. So it talks about good care from the perspective of the patient, and it talks about good care during the whole patient journey. So from recognizing there's a problem until a long time support in the community. So what do we know about borderline intellectual functioning? And I always mention first that there are people like you and me. That's because a lot of my colleagues, psychiatrists, think that if you have borderline intellectual functioning, you can see that from a mile away. Those people are very different. Sometimes my colleagues ask, can you talk to those people? Can they talk back? Yes, they can. They're just normal people. Because actually borderline intellectual functioning is a variant of normal intelligence. It's not a disorder. It's not a disability. There are no distinct features, no specific behavioral phenotypes, but they do form a very vulnerable group. As I said before, an estimated 61% of people who have borderline intellectual functioning experience problems in adaptive behavior. And if you look at that door ajar to ID care and support, we see that in general there's an increase of about 6% in the demand for ID care and support, but for people with borderline intellectual functioning, this increase is about 15% a year. So new people coming into the ID care and support system are more likely to have borderline intellectual functioning. So, of course, people thought about the reasons behind this, and there's a report called Care Better Understood that looked into the reasons why, especially people with borderline intellectual functioning, have an increased need of support, and they think that the complexity of society plays a big role in that. Like the higher demands in education, there are fewer low-skilled jobs. Digitization is a big problem in the Netherlands, and there's limited social support for people with borderline intellectual functioning. So one of the examples of digitization is that they, I don't know if any of you ever have been to the Netherlands and tried to use public transportation. Well, it is a difficult system where you have to have a special card and you have to put money on there, and if you don't have enough money on it, then they won't let you in. You have to check in and check out. Apparently, and I've never seen it, but I kind of can understand that they did a research project on like how smart you have to be to use public transportation in the Netherlands. And they said, well, if you have an IQ like below 85, you just can't do it, which means that like about 15% of Dutch people actually have difficulties using the public transportation in our country. So a very vulnerable group. They have an increased risk of almost everything. Experiencing physical problems, that's something Roger already mentioned. Poverty or socioeconomic disadvantage, poor parenting, children with borderline intellectual functioning, and this is a research project done by Fanning and colleagues a couple of years ago, and they found that that parents of children with borderline intellectual functioning were less likely to offer positive parenting and positive support to their children with borderline intellectual functioning than to children of normal intelligence and compared to children with intellectual disability. And also they found that parents of children with borderline intellectual functioning perceive their children to be more problematic than other children, even though they were not if you compared them. People with borderline intellectual functioning also experience more difficulties with activities of daily living, more psychosocial problems, so problems in school, problems in work, problems with finances, and so on and so forth. They have a higher risk of ending up in the criminal justice system, and this is especially a huge problem in the Netherlands in youth, where that about 30% of children, young children and adolescents who are in the criminal justice system are thought to have either borderline intellectual functioning or mild intellectual disability. The percentage of problematic alcohol or drug use is higher in people with borderline intellectual functioning and in mild ID, which means that they're not more likely to be addicted to drugs or alcohol, but if they do use alcohol or drugs, they get into all kinds of different problems much faster than people with average or above average intelligence. And the last, of course, is mental health problems. They are at a higher risk for all psychiatric disorders, and especially some research is showing, and of course this is all very new research and we have to retest this, but it talks about psychotic disorders being more prevalent, post-traumatic stress disorder being far more prevalent, personality disorder or at least difficulty in forming a balanced personality, and again the problematic alcohol or drug use. And again, when they do have a mental health issue or mental health problem, they also very often have all kinds of different comorbid psychosocial problems, which often make it a very complex, very complex mix of all different kind of problems. So if I see a patient, it's never somebody who just has a depressive disorder or an anxiety disorder. It's also very often problems in the workplace, relationship problems with the children, financial problems, and you always have to look very carefully, like what is the main issue and where can we start to make things better. So using that screening instrument that I talked about before, we know a little about the prevalence of borderline intellectual functioning and also mild intellectual disability in general mental health care. And the numbers are actually very high. It's between, if you look at the front door, like new outpatients coming in, we think about 1 in 5 new patients is likely to have either borderline intellectual functioning or mild intellectual disability, and that percentage is over 50% of people who have severe psychiatric disorders. And the thing about these numbers are, it's a bit of a warning, that we don't differentiate using that screening instrument between people who have developmental borderline intellectual functioning and people who have cognitive dysfunction because of the severity of the psychiatric disorder. So that 50% might be overrated, but then again, these people do function at the level of borderline intellectual functioning or mild ID at the moment they are tested and they are in inpatient care, and not taking into account the level of functioning might make it very much more difficult to get them to leave the hospital. So the other thing is that these people go mostly unrecognized. Few patients in general mental health care are classified as having borderline intellectual functioning, and mental health care professionals find it very difficult to recognize these low IQs in their patients. I did a little research project myself a couple of years ago, and what we did is we talked to mental health care professionals about both borderline intellectual functioning and mild intellectual disability. So we explained this is what we're talking about. We used the screening instruments to see which patients were likely to have borderline intellectual functioning, and we asked the mental health care professionals, like the patient that you just saw, do you think this patient might have a low IQ, might have borderline intellectual functioning? And even in this setting, mental health care professionals only guessed right in half of the cases, so the positive predictive value was very low. So we're not good at recognizing it in our patients. We know that people with borderline intellectual functioning are much more likely to be treated with medication and with psychotherapy, and very often they get a lot of medication, and it doesn't always work. And we also know, and this is research done by Jeanette Nieuwenhuis, which is a colleague of mine in the Netherlands, is that people with borderline intellectual functioning or mild intellectual disability are not only very likely to be hospitalized, but they also have a higher risk of involuntary admissions and coercive measures. So how about the other side, like in ID care? We know that borderline intellectual functioning people comprise a very vulnerable group in ID care as well. Socioeconomically, they often end up being homeless for a while before they enter ID care. Again, the parental problems compared to people with mild ID, and this is research done by Peter Nouwens, which is also a Dutch colleague of mine. If you compare the people with borderline intellectual functioning in ID care to the people with mild ID in ID care, you see that actually the higher functioning people, so the ones who have borderline intellectual functioning, have the most difficult problems. And that is because more often than people with ID, they experience a lot of difficulties from early childhood with divorce, inconsistent parenting, neglect, parents who have mental health problems or addictive problems. So they experience a lot of issues from early childhood on. They also found that a lot of people with borderline intellectual functioning in ID actually have problems using alcohol or drugs, but most of those people do not get any specialized treatment for it. So they are using alcohol and drugs, problematic use, addiction, but they don't get any treatment for it. And so I already said about somewhere in between 17 and over 50% of people in mental health care are likely to have either borderline intellectual functioning or mild ID, and the other way around, about 30 to 60% of people in specialized ID care, including the people with borderline intellectual functioning, have mental health problems. So like the overlap is huge. What we find in the Netherlands, and probably in Finland it won't be so different, is in mental health care, there's a lack of knowledge on ID and borderline intellectual functioning. There's also a lack of knowledge on mental health problems in the care for people with intellectual disability. And that might be the reason why mental health problems often go unrecognized and often also go untreated in ID care. So what we have in the Netherlands that I'm actually very proud of is a new standard quality of care on mental health and borderline intellectual functioning or mild intellectual disability that talks about core elements of good care, and it's meant to be used both in mental health care and in ID care, trying to bring those a little bit more together. And the core elements of good care that we describe in this standard quality of care is the importance of recognition, the importance of adjusting your communication and interaction, understanding the interaction or the interference between the low IQ or the borderline intellectual functioning, mild ID, and the mental health problems. We talk about the importance of a multidimensional view and a tailor-made approach. So recognition is everything. All else fails if we do not recognize that in people who have both borderline intellectual functioning and mental health problem, that they have both borderline intellectual functioning and mental health problems. So we're focusing a lot on recognition of borderline intellectual functioning in mental health care and on mental health problems in ID care, because we know once you recognize that both is there, you can start as soon as possible with adjusting your communication and interaction, which is helpful in therapy. So the other core element is that we're trying to get people to understand that when you have both psychiatric disorder and borderline intellectual functioning, that there's always an interaction between the two. And this interaction could be a very mild interaction, but it can also be a very severe interaction, making it very difficult to distinguish between what symptoms or behaviors are part of the borderline intellectual functioning or mild ID and which ones belong to the mental health problem. To better understand that interference or that interaction, we talk about using a multidimensional view. And in mental health care, we are trained to look at the disorder, recognize the disorder and treat the disorder. But in people with borderline intellectual functioning, or in people with ID for that matter, we try to teach people to have a much broader view and also look at the aspects of borderline intellectual functioning, like IQ and adaptive functioning, but also look at emotional development, look at the context, and look at the somatic aspects of a person, so that we better understand the whole deal of problems people are dealing with. And then when it comes to treatment, this standard quality of care describes a tailor-made approach, which is like something we kind of made up or use to let people understand that when you have borderline intellectual functioning, that doesn't mean that you have to do something completely different. A lot of my colleagues tell me, like, yeah, he has an IQ of 80, I don't know what to do, I can't treat this patient for his mental health problem. And what we're trying to tell people is, it's not that different, it's not that difficult, as long as you recognize that both is there. You can use regular guidelines, you can use regular protocols, but you just have to take into account the borderline intellectual functioning, which means that you have to think about the way you talk, you have to think about making your therapies more concrete, taking smaller steps, you have to think about generalization, but you still have to use the regular guidelines and protocols. And we call that a tailor-made approach. And points of interest in this tailor-made approach are that people have to be flexible using procedures, that people have to think about a preparatory training. For instance, when you use cognitive behavioral therapy, it's good to know before you start if people can differentiate well between cognitive and behavior, if people understand emotions and know what to call those. Simplify your communication, of course. Always consider commitment and involvement of the patient support system, and this can also be a support worker. But the most important thing is the willingness of the therapist to adapt to the patient, because what we see in mental health care is often professionals want the patients to step up to their level, and what we're trying to say is, please try and get to the level of your patients instead of asking your patient to do better. Another core element of good care is organizing support. What we see is that support is really something that we organize very well in ID care, and treatment is something that we organize very well in mental health care, but it's like two separate worlds, and they don't often come together. And we stress the importance of support, and this can be practical support, like making sure that the client or the patient gets to therapy or is able to pay for transportation, but it's also, and very importantly, supporting the treatment, like making sure that you know what the patient has to do or what the client has to do for homework, giving the right compliments, taking away barriers in, for instance, doing homework. So that is a very important part as well. And the third kind of support that we talk about in that standard quality of care is support and coaching of the context of the system, like letting teachers, parents, other family members or bosses know what this person is about, what the care needs are and the support needs are at that moment, because also they might be different when somebody is experiencing a mental health problem. So the last thing that is we talk about in this standard quality of care is the organization of care. It talks about clear referral pathways, making sure that people get the right treatment at the right place at the right time. It also talks about collaboration between ID care and mental health care, because we see very often right now it's either or. People are in ID care and then they are like sent to mental health care, or they get sent back to ID care. And what we try to do is form more integrative forms of care for people who have and mental health problems and borderline intellectual functioning. And a big part of that is communication, because what we see is it's very difficult for ID care and mental health care to talk together about patients and just come up with one way and one view to integrate the care. And to end up, I have this this guy is very famous in the Netherlands. It's Dr. Sigmund, and it's in Dutch, so you can't read it, but it's about exclusion of people with borderline intellectual functioning in mental health care, which was a big issue a couple of months ago in the Netherlands. And what he says actually to the patients is that he says, I'm sorry, your IQ is too low for treatment. You're just not smart enough. And then she comes home to her husband and she says, like, yes, I'm too stupid to be depressed. And her husband says, oh God, now this. So some ideas for now and the future, like what are we trying to do in the Netherlands? Raising awareness is a big part. Borderline intellectual functioning is a very common comorbid disorder in mental health care. We try to include borderline intellectual functioning in more of the regular quality standards of care, because of course it's very good to have your own quality standard of care, but how great would it be if the standard of care on depression, for instance, or psychotic disorders would also explicitly include people with borderline intellectual functioning? So that's something we're working on. We're trying to incorporate knowledge on borderline intellectual functioning and mental health in regular teaching programs for professionals, both in mental health care and ID care, because that's something that's just not done right now. And we're trying to ask attention for specific inclusion of borderline intellectual functioning in mental health care, which also again is about clear referral pathway, but it's also about enabling people with borderline intellectual functioning to enter the mental health care system by making sure that the information they get is understandable, making sure that the communication is attuned to people with borderline intellectual functioning, and so forth and so on. So thank you for your attention.
We're going to actually change the program slightly and have the coffee break now. It will be a shorter coffee break for about 20 minutes. And then we will continue the program after that. I'm sure people can ask Jan Lind questions over coffee or Ken or anybody. If you're happy to do that, somebody needs to translate for me.
The coffee is over there.